Hey, everybody, welcome. We're giving folks a few more minutes to join. We know it's lunchtime. Hopefully people can grab something to eat while they're on today. Just give it a few more minutes. Maybe you guys could just put in the chat box real quickly who's with us today. I'm trying to remember, but I just don't always get it straight. You guys are spread out across the state, but if people want to just let me know who they are, what center you're from, and what role you play in your center, that would be great. And we'll start about 5 after. We'll just give everybody a chance to get here. Valerie, it's great to have you right down the street from me.
Yeah, thank you.
Are you one of the regular therapists in the organization?
Yeah, I'm here at Minnie Jones. I've been here since last July, and I'm trying to mostly work with kids. It's been a little challenging to fill my schedule with kids just based on their school schedules and everything. But yeah, we're able to offer some services for youth now, which is awesome.
Are you guys doing school-based health?
We are doing it in McDowell County, and we will start doing it at Nashville City Schools in the fall. So
Oh, wow.
in a
That's
couple schools
great.
along with Michelle, who also just hopped on. It's also from Winches.
Well, that'll fill your schedule. At
Oh, yeah.
least then you have the half the summer, a little lighter schedule. So Michelle, you're from Winches also? We for those of you on the phone, our locals, we like to call, we say Winches, right, Valerie?
Exactly, yeah.
I think everyone has their name. Where are other folks from? Where's Sarah and Yanira? Michelle, I think I heard you're from Winches. Yanira, make sure I say it right.
Yeah, I usually
Dawn?
go by Yanni. I'm the program assistant at Winches for behavioral health.
Oh, that's right, Yanni. I met you.
Yeah.
There's a
I'm
lot.
not used to that version of your name. A good representation here from Asheville, I have to say. Dawn, where are you from? You're muted.
Craven County.
Where is that? Help me out.
It's out towards the beach, Morehead City, Newbern.
I am headed to Wilmington. I'm headed to Carolina Beach tomorrow afternoon. Gonna
Just
go
a little
down for
south of us.
going down for Mother's Day. My mom's in Wilmington at Carolina Beach, so yeah. I was raised mostly down by Elizabethtown. That's where I spent all until I graduated from high school. Where are other folks from? Tasha is from UNC Health Party. Okay.
Yes, I am. LCSW and just starting this integrated care, so very new at this.
Tasha, are you doing kind of traditional briefer therapies in primary care? Are you doing collaborative care? What does it look like?
I'm doing we want to right now start or do the brief therapy. However, since resources are so limited, it's almost like we're functioning as an outpatient behavioral health center, if that makes sense.
Oh yeah, that's hard because that's a tough use of resources, you know, like
Yes.
you say, and you want to do a brief intervention model. That's a lot of what we've been talking about on these calls. If you recreate what's on the outside, then you'll have the waiting list and the frustration that goes, you know, with doing
Absolutely.
more traditional work. And then everyone that wanted integrated care, yay, integrated care is going to go, wait a minute, this is just as bad as regular care.
Exactly.
And it's not that it's bad, it's that the waiting list and the access just plummeted.
Yeah, you're
Yeah.
exactly right. I really learned a lot when you talked, I don't know if it was last week or the week before, about actual, brief interventions like the written exposure therapy, because, as everyone, I'm sure we see so much trauma.
And my thought about written exposure therapy is if the VA can do it, test it, and make it work, we can make it work.
Absolutely. Agreed.
Sometimes things have all this mystery around them, and literally, I just went on the internet and found a slide deck, a presentation from a member of the armed services who was doing a training for her staff.
Oh, interesting. Okay.
So I
Good
didn't
to
have
know.
I didn't have to go buy the book or take a class. All you had to do is look at her slides. She had step by step by step exactly what you do. And she recorded all the questions that
Oh,
came
interesting.
in at the end of her talk. So it even has the whole list of questions, because people had a bunch of questions about it. It's a new
Right.
brief. What am I supposed to do here? Sort of treatment.
Exactly. I'll
And I
definitely
think
look into that.
Yeah, I think we do have to, really think this through in primary care. And I am, we have the same problem here. If they don't get treated in primary care, they may not get treated anywhere. It's not
Yep.
like, okay, primary care didn't work, let's refer to community mental health, because
Right.
community mental health doesn't exist. And a lot of the places, or it's a long drive, right? And if they don't keep
Exactly.
appointments, they get discharged. I mean, we just don't have a very good system in community mental health to keep track and keep up with people. So,
Agreed.
yeah.
Agreed.
Stephen, where are you from? Or whoever's using Stephen. Sometimes people are on other people's phones. Stephen, what part of the state are you from? Yep. I know where Jessica's from. She's on the phone driving across town, I think. And then Sarah.
Hey, good morning, all. I'm Sarah Mascarelli. I am in Raleigh. I am with the Center of Excellence for Integrated Care with the Foundation for Health Leadership and Innovation, and luckily got to be included. And I have had conflicting meetings up until this week, so I'm grateful to be able to catch some of what y'all have been sharing in these meetings.
And so Sarah, I'm thinking you might know the background, but the North Carolina branch of basically it's the group for the federally qualified health centers, the community health centers, their behavioral health director, Justin, came and asked the Mental Health Transfer Technology Center at Emory to help with frontline behavioral health people really struggling with the burden of mental health going on that these guys are facing every single day in primary care, in the trenches, and for us to see if we could come up with 5 or 6 different topics. Everyone got a chance to put in a survey what they might like to hear. We picked from your list, and we've been going through those sort of systematically. And the week before last, we did evidence-based brief interventions, and I think that's what we were just talking about, I think, with Valerie. And a new one we found that the VA is using that's brief and works in amazing ways, it looks to me. And then last week we talked about special populations, because that's the other thing people wanted help with. Is I got geriatrics, pediatrics, perinatal, I got all these folks coming in. I'm not trained in that, but I'll tell you guys, if you ever say to a primary care provider, I'm not trained in child, I don't know what to do, they're going to look at you and say, well, you know more than I do, so I need your help. So as much as we can be generalists, so we talked about how to adapt integration to special populations. And I've already heard some of you are working with peds. I'd be curious about perinatal and let's see, geriatric we talked about last time. And so we gave some resources and training around this is what's different. We didn't do substance use. That's an entire talk on its own. But we did those 3 populations because that those are the ones that come through that we're not always sure what to do about. And so typically today's office hours is, does anyone have any questions about last week or observations or something you tried in the over the last week since we met? And then it's open. You can talk about anything you want. I'm not picky. And then next week, we're going to go into a discussion because we've talked about all kinds of stuff. Written exposure therapy, brief interventions, all kinds of stuff, special populations. And next week, we're going to talk about, because folks sometimes are skeptical. I was trained in a very psychodynamic psychotherapy, psychiatry program. I sat with patients 3 times a week for an hour. Man, when I left that program, I left it way far behind. Number one, it gave me a headache to do that. And number two, it just didn't seem to be all that useful. So like many of you, I am trained in the 50-minute hour. And so it's often difficult to hear about these brief interventions if the only thing you've been trained in is the 50-minute hour, which is, very, very common. And so next week, what we're going to ask is the question, well, how do you know it's working? How do I know my written expressive therapy is working? How do I know these brief interventions? How do I know what I just did with this geriatric patient was worth anything? Did they get better or not? So next week, we're going to talk about the common tools, not the screening tools. Everyone has to screen for depression. That's an FQHC/HRSA requirement. Y'all got to do it. And y'all probably all know if your number is 56 or 26 or 86, you guys could probably spout off what your number is. What we're going to talk about next week is not just the base, let's call it the baseline measurement, but until they are discharged from your care, how do you know they're getting better? What if they're not? What if they are? What do you do with that information? So it kind of brings us full circle from what we've been talking about. It brings us full circle around to, is it working? And I really hope as we go through these topics, we've done how to engage your PCPs. We want them to actually refer you patients. If they don't, integrated care doesn't happen. The brief interventions, the special populations, we really want to come around full circle now to, is all this just a bunch of hooey or does it work? So that's where we're going to go next week, is helping you with validated measurement tools so that you have a good sense. And if something's not working, how do you adjust care? Because if something's not working, you just don't keep banging away at it. You actually find something new to do, find something different to do. So we will talk about that more at length next week. But what I want to do right now is just sort of pause and see if folks had either experiences, things they tried in the past week, either with special populations or brief interventions, or trying to engage your PCP. The 3 topics we've talked about, what kind of experiences if folks have? Jessica, I think you just came off mute. I don't know if that was intentional.
Nope, I'm sorry. It's probably a little loud too.
That's okay. Anybody on Jessica's team? You guys have several folks here. What have you guys tried? What have you guys thought about over these 3 weeks, or anything you've tried in your practice right down the street from me? What does that look like? There's Krista. You're muted, Krista.
Sorry, I tried to join from my car. I had to drop off a coworker to pick up their car and my phone wouldn't cooperate. And I have Francis with me as well.
Hey,
Francis Earnhardt.
Hi.
Krista, anything you've used since we've been talking? And I know you guys have a special kind of practice and approach. I'm so excited about you guys coming on as collaborative care.
I know we are too.
After the
I haven't personally. I was on vacation last week, so I'm back now. We have a new intern. There's just a lot of. I haven't done as much direct patient care as I normally do.
Mhm. And Krista, I don't know if any of you guys are going to the summit next Thursday. Krista, I know you're going.
Mhm.
But there's a summit in Raleigh for people that are thinking about becoming the collaborative care specialist, collaborative care provider, collaborative care care manager, all kinds of different
Collaborator.
names. Collaborator. In the collaborative care model that AHEC is spreading across the state. So Krista has stepped up and she's going to be one of those folks along with Ted Hughes at her organization. So we are having a training for all these potential people who want to do collaborative care in Raleigh all next Thursday. So Krista, I will see you. You're staying at the Holiday Inn, right?
Mhm.
Okay, me too.
And I'm
Well,
staying Friday for the clinical
updates.
update. Mhm.
Anybody else going to clinical updates on the call, even if you're not going to the collaborative care thing? People heard about that. It's really nice behavioral health clinical updates put on by somebody. I don't know who. I think Duke's been organizing it, but it's for therapists. It's kind of like what we've been doing here is, man, getting whatever you can whenever you can. I think it's free, but I don't know if anyone else is going to do it. It was okay. All right, so folks, what you been doing? What you been thinking about since our last training? Did any of that resonate, or are these things you've tried with those special populations, or do you have something else you've tried that you want to share with the group?
Nathan wasn't able to be on today. I know that he's been discussing implementing some of the shorter term interventions, but he can't be here today.
Okay. And those shorter term interventions they're kind of at the heart of collaborative care, and they're necessary for billing, and they are, again, not meant to be 45, 50-minute psychotherapy visits. That's not the spirit of what we're trying to do, is increase access. And I think that's the other thing for folks to remember is when we talk about these briefer interventions, we're talking about something that works. And if you do them, you increase access for more people to get behavioral health treatment. Because we are not going to address the need, we're not going to address the workforce shortage. And for folks that might be interested, Krista, I'm going to talk about you for a second. Krista and Ted are QPs, and they've been working in behavioral health for how long? 10, 15 years?
Longer. Yeah, I've been here. I've been at my clinic 16 years, but I've been in the field since 95, and Ted about the same.
I want people to also think broader on this call about who's your broader behavioral health workforce, because Krista and Ted are not licensed therapists. They are QPs. I think that stands for qualified professionals who have been doing mental health for 10 or 15 years and who are now going to step into the collaborative care specialist role doing the brief interventions. Remember on our brief interventions, one of those slides, I said, a lot of this is manualized. It's easy to learn. You don't have to have a license to do it. And so Krista and Ted are going to be a really nice test case for us, proving, in fact, that is possible. So they're going to the training on Thursday with me. I'm so excited because we have to think about who the broader behavioral health workforce, and I'm thinking really broad, pastors, doulas, EMTs, it really has to be a lot bigger workforce because you guys are all stressed. I don't know how big your caseloads are, but we're all stressed in mental health trying to do it on our own. So I'm really excited about what Winches is trying to do with their staffing. Anybody else trying anything a little out of the box?
I just wanted to mention something also. This is Jessica. So we have Amy Morris on the call too, and she will also be part of our collaborative care team at Winches. And she is already doing a lot of great integrated care. So it is going to be, I think, a great transition with collaborative care. Amy, do you want to share a little bit about what you're doing and how you're working with the medical providers?
I'm not sure she heard you, Jessica.
Yeah, I'm not sure either.
We'll get her back.
Hey, Amy. Or maybe she's having trouble unmuting.
There she goes.
Did you hear what I asked, Amy?
No, I'm sorry. I'm in the meeting, but I'm also kind of attending to a patient. It's needs.
Oh, no problem. And if you need to jump off, that's fine. But
Okay.
I was just sharing with the group the great integrated care work that you're doing in your pod, and how you'll be a part of collaborative care as well. I don't know if you're able to share now about what you're doing and any interventions, or if you need to come back to us.
No, I can share briefly. I'm located in our OB pod, so that I can kind of be readily available to the OB providers here, but we also have some family medical providers. So I'm here in the pod. I do have my own schedule of patients that are coming in that I'm doing behavioral health screenings on, and then getting them linked with appropriate level of care, whether it's here or outside of our clinic. I see pregnant women, postpartum, and then I see folks who are just here for primary care. Some who are in between stages of, getting meds from PCPs, or maybe needing to be linked to an outside provider, a higher level of care. Some who just need to maybe be linked with a therapist within our clinic, and their PCP will continue their meds. And then there's some that kind of fall in the middle. But that's what I do. Yeah.
So Amy, you've got that perinatal population that we talked about last week.
Yes.
Did you do a lot of traditional integrated care before you came over to the OB pod?
Yes. Yes.
So you heard kind of what I said last week, but I always want to hear what you found out. So how would you share your knowledge of that with your colleagues here on what's special, what's different? What do you need to do in integrated care that's different with this population?
With OB or the primary care?
OB.
I did listen to your meeting last week, and all of those things were things that we have in place here. Typically, I meet with folks when they're pregnant. I usually meet with them at the beginning of their pregnancy if we've identified any history of behavioral health issues or postpartum issues or substance use issues or serious life stressors. So I meet with them and do a behavioral health screening and see what they need, and then refer them out or keep them in, referring to one of our therapists, or, there are times our OB providers take on the meds here if they're comfortable with that. If not, we did have a psychiatric nurse practitioner who was prescribing, and we're looking to replace her now. And that's where I would send some folks. The differences are, I think they need to be seen a little bit more often, usually just to check in periodically throughout their pregnancy. I think they need to be really well educated from the beginning of their pregnancy, just kind of what to look out for with their moods and how to get in touch with us if there's support that's needed. There's a lot of discussion around like postpartum symptoms and what that can look like, and just sort of building that rapport so that if there are issues, they feel comfortable reporting that to us in the postpartum period so we can help. I talk to them a lot about sleep and self-care and who's going to help you with the baby and those types of things, to kind of get them ready before they have their babies. And then again, just, they can easily contact me. We also have behavioral health triage here if I'm out or anything, but they can contact me if they're having any mood issues or sleep issues. And then we kind of go from there. I've had, lots of folks with postpartum mood disorders, anxiety, depression. We've had very few over the last decade with, a little bit of maybe postpartum, like a little bit more. I'm trying to think what the word is. My brain is not telling me the word.
Psychosis or
Psychosis,
postpartum
sorry.
depression? Okay.
We've had
Wow.
like a handful of folks that have had postpartum psychosis. And, some of those we've needed to link with higher level of care pretty immediately. Some of those we've worked with mobile crisis. They'll come to our clinic and help with the patients. And then some of them, just different odd cases, we're able to talk to the PCP and work things out and just keep a close eye on that patient, with a team in place.
What tool are you guys using, the Edinburgh or the PHQ-9, or what are you guys using?
Both.
Okay.
So the screening that I do in the beginning, actually I do a PHQ-9, a GAD-7, a PTSD-5, and then some substance use screenings as well, just to try to identify if there's any issues in the beginning of the pregnancy. And then towards the end, throughout the pregnancy, we check their PHQ-9. At the end of the pregnancy, we do PHQ-9, but we also do an Edinburgh because it captures some other things that happen with postpartum that are really specific, that help us figure out what's going on with the patient.
That's great. You've got it sounds like you guys are really cooking. How, is this a new program or you've been doing it for a while?
I've been in the OB here for, I don't know, Krista maybe can help me. I think about 9 years, maybe 10 years.
Wow.
And we did some of that prior to me coming here. But then once I came and was in the pod, we were able to implement a lot more steps to educate and reach out and take care of some of these folks.
Well, Amy, I'm really excited about you helping launch the new collaborative care program with Krista and Ted. I think that's going to be exciting. Who's doing pediatrics? Who's got pediatric integrated care? Krista, you've got that. Anyone in addition? Valerie, you've got it. Valerie, talk a little bit about how pediatrics is different, and I guess the biggest thing is, what are all those age-related screens and issues that you see?
Well, I guess even though Amy and Krista and Ted and I are all in the same facility, like their role is maybe more integrated than mine actually is. So often those folks are seeing the patients, like they're the first kind of person that they see, establishing that rapport and connecting them to just the idea of mental health in the first place. And then they may get referred to me for therapy. So I am doing more of sort of conventional therapy, and I think that might shift with the collaborative care model as well. But the screenings that we use so for folks under 12, I think we talked about some of these last time, but the CRAFT, the SCARED, the PEARLS, which is like a pediatric ACEs that's filled out by the caregiver and the patient. I'm trying to think what else we have. The pediatric symptom checklist 17, which is really helpful. And then that'll be the initial screening process. And then when they get referred for an assessment, we'll do some further screening and assessment based on kind of what's popping up with those.
So Vanderbilt or whatever, if it's or SCARED or kind of whatever else you're looking for. There's so many because you have to go by each age you know, from 5.5 up, it just keeps changing what you use. So it does make it a little trickier. Anyone else doing child or have any pearls around what's a little different in primary care about treating children?
I mean, I do also meet with some children, adolescents. I think it's a little bit trickier around, you know, just giving them a little bit of time, you know, to talk on their own if possible. And also, you know, feedback from the guardian or parent. A lot of those folks, you know, some of them we keep and we do some in-house therapy, and a lot of them have higher needs than we can meet. And so we do refer some of those folks out. But I think the biggest thing is, you know, the way that you build rapport with kiddos is usually a little bit different than the adults. And that may take some extra time.
And I would like to add that sometimes the kids are on board and they're interested and they're asking for the care, but the parent or guardian isn't as invested or can't connect the dots for the kid, even like for a video visit. Like sometimes the parents are not as invested or they don't understand the same importance of having some interventions as the kid might.
But in all the cases, the interventions are very similar. You just adjust it for the age group that you're working with. Most of the integrated behavioral health specialists or QPs, we're not master's level therapists, and we're the ones that usually use most of those, you know, like the motivational interviewing, behavioral activation, those types of things that you're talking about. And you can use them with adults and kids just in a little bit different ways.
I think that's important, adjusting it for the population. Because we'll hear things, you know, like CBT is the best thing for child, adolescent depression and anxiety. And it's not always something that we can offer. We might be able to offer a modified version of it. But to know that you can modify many of these brief interventions that we talked about directly to the pediatric population. I had a family member who was 14 at the time, pretty depressed. And the pediatrician just looked at him and said, "Is there anything you can do to help you feel better?" And he said, "No." And that's where they left the conversation, you know, so that's not behavioral activation, right? And you guys have a sense of what it is. So I just, you know, it's like, oh, you know, not really knowing what you know, what that approach is, how easy it can be, and how important follow-up is, you know, how important it is to follow the evidence base was a little frustrating to hear. So I think for everybody, that's just an important piece. Same many of the interventions are the same, you just adjust them to the population. And then how about geriatrics? Are you seeing with some dementia, you're using the MOCA or other tools, or how are you adjusting? Just like Amy was saying, how are you adjusting what you're doing for a geriatric patient who may be struggling with health issues, memory issues? How do you tweak your approach? And do you do dementia screening? And what tools do you use?
Those screenings in our primary care clinic are typically initiated by the PCP to help them determine if they should be referred to neuro. But sometimes we also do some short-term intervention. Sometimes that's another scenario where sometimes you have to have the family investment and involvement to carry out the plan well. So we do spend quite a bit of time educating family members as well as the patient about what the options are.
Yeah, I think, you know, it's a little different from our usual adult population is how when we get to peds and even OB and geriatrics, how there's a larger group, which, you know, if you're used to that room to room to room integrated behavioral health, doing brief interventions, this is going to slow you down a little bit. because there's other things you need to do. Do you guys get warm handoffs from the PCP if the MOCA, if the score is low, if there's a problem? And then what does the PCP hope you will do with them?
Sometimes it's about helping them accept that they're having some cognitive decline. Sometimes they're emotional about it, or they are resistant to hearing it. And so sometimes we are brought in to use some education and motivational interviewing to help them see the benefit of exploring the cognitive decline further. That maybe getting on some medication to slow down the progression, or just kind of, if they're afraid to go to another doctor, sometimes that's the case. So we'll just kind of like walk through with them what they could expect to help them be less anxious about it. So I think we do a lot more short-term interventions than we really realize.
That's great. That sort of acceptance, and the family member too. I remember a guy came in and with his wife, and he didn't even really realize it. To him, he didn't notice the cognitive decline. She noticed he no longer played golf. He no longer did this. He no longer did that. She's so frustrated. They used to travel. They used to do all these things. And he was perfectly content sitting and drinking coffee and reading in the morning, and had lost all, interest. He looked relatively happy. He didn't seem depressed, but he was the identified patient. She was clearly the patient, because she was having a tough time with the dramatic change in her spouse. Yeah. So sometimes with kids, with peds, not so much with perinatal. Sometimes I think the problem with perinatal, sometimes your moms are going alone. But there may be a different patient than the patient the PCP hands off to you, right? And just a different way you got to think about who needs what here, because it's not necessarily the person that I was referred. Yeah.
Yeah, I was gonna add that about peds, especially I think if you're doing like brief interventions, sometimes the interventions with the parents are just as valuable. Like if especially if it seems like it's going to be a challenge to get the kid into like consistent treatment or develop a long-term relationship with them. Sometimes I'll just really work with the parents on like behavior management or helping the kid use coping skills, or whatever the parent's going to be able to do more consistently is going to have more of an impact than whatever I can do for an hour every 2 weeks or once a month.
Yeah. I mean, I think that's another piece to remember, is what's keeping it going between those sessions. And one of the nice things, some of you guys, probably many of you have some form of homework assignment for the patient, for the family. But specifically with things like behavioral activation, problem solving therapy, there is homework. There's a worksheet you send with them. But there really is that we got to keep this going in between visits. We got to have some way, because we don't have enough time to actually meet one-on-one. How do we actually keep the treatment going in between visits? I think that's just sort of an interesting thing that we all need to think about. Are any of you using apps or online CBT, or, online relaxation or exercise? Anything in particular you guys encourage your patients to do in the spirit of kind of self-management and keeping that going between visits?
I don't do very much online. I do a lot of handouts, and like practicing things with patients and sending them home with a plan to do it themselves, and then come back and check back in and see how that's helping. I don't do a whole lot of apps, though. I think there's been a couple of kids in the past that maybe I tried an app with, but not much.
How about online CBT? Because sometimes your organizations, and Jessica, I don't know if you guys are doing this, but your organization will specifically license one. So we licensed, this was 15 years ago, Beat the Blues, which was one of the first online CBT companies. And so we would give our patients, here's the sign-in number, here's the code. And we had a license for up to 50 patients to sign up. And then we would use that as the sort of in between something else they can do. But I remember it was Beat the Blues. I don't even know if those guys are still around. But and I don't know if any of you do that or license it, but that is something quite common for organizations like yours to use at this point. You can license the app, you can license online therapy. I got something Teladoc from my insurance company the other day and said, hey, if you want to call in and get some mental health treatment, here you go. I'm like, wow. A lot of places are doing it because they know what the access to behavioral health is like. And so we just sort of call them, you know, their patient facing behavioral health management tools. And it really does help keep. There's nice ones for substance use, I hear. And Valerie, the CBT for insomnia one from the VA, oh my gosh, it's free because it's the VA, right? I would encourage you guys, any of your patients with insomnia, almost everybody has a smartphone. Do it for yourself. It's a really cool app to help people change the way they are thinking about sleep. Because a lot of people lay there anxious because they're not sleeping and their mind keeps going, I'm not going to sleep. Oh gosh, I'm not going to sleep. I'm going to be tired tomorrow. I'm not going to do well at work. How do we kind of slow down, prepare ourselves for sleep, so good sleep hygiene, but also correct those thoughts that might be those negative thought patterns that might be going on because you can't sleep. So that is a fabulous one and it's free. You've already paid your taxes. So that one you get for free. And it's a good one. And this isn't just it's not a crappy app. It's a good one. And CBTI, we're running into things now where everyone's, got obstructive sleep apnea. That's sort of a big thing right now. And a lot of insurance companies are pushing back a little bit and saying, hey, I want you to have a trial of CBTI before we approve your CPAP machine. So, we're starting to see a little pushback on that. And because CBTI has such good evidence, we didn't get to everything in our brief interventions, but CBTI has more evidence than sleep medications for sleep. So, just keep in mind that is something that you can use. Calm is supposed to be a pretty good one for anxiety, but I think Calm costs. But it's one, again, you guys could get a grant or whatever and license an app for a year and see how many of your patients use it. That sort of thing. Headspace is pretty big. Again, that one costs. Calm may not cost. I can't remember, but just a few that I've poked around on. I wish someone would give me a list, but no one will because there's 15,000 behavioral health apps out there right now. We don't know which ones are good, which ones are harmful. There are some guidelines on how to pick them out. I think the American Psychiatric Association has a website you can go to and use that list. Does it do harm? Does it have a randomized control trial? Blah, blah. It has all that good stuff. But just something to think about for your organization. If you don't have enough mental health people, and if anyone has enough, please raise your hand. I would be surprised. But if you don't have enough mental health people, it really is a way to extend the workforce that you have. So you see them, but in between they do a module of CBT on this website next week before I see you back. That sort of thing. Again, another brief intervention helping you out and helping the patient. Anybody else use an app besides the CBT for insomnia? I've personally used Headspace and I've personally used Calm just to see what they're like. Oh, and I have a mindfulness bell on my phone right now. It goes off. I used to have it on half the time you hear it when I'm sitting here. And it just is a reminder, ooh, take a breath and relax. Put your shoulders down. So even just this little tiny thing that, it takes 5 seconds, 10 seconds to do, it can be just very, very helpful. part of that adaptive DBT skills, right? Where we're teaching relaxation. What about other folks? Maybe for some from, Stephen, I don't know what site you're from. I think we've heard from everybody else.
Yeah, Kinston Community Health.
I'm sorry, Stephen?
Kinston Community Health in Kinston.
Okay. And what has your experience been kind of going through these different, the coursework and, or the things we've been talking about, or anything you may have tried in the last couple of weeks as we've been going through this?
Well, I know our, I'm not a LCS deputy, by the way, but I know our counselors do assign homework and the patients tend to do it, and they have good outcomes with that, it seems. We have historically been a more traditional model without any actual integrative healthcare really going on, but we're looking at trying to implement that going forward and get into doing the more integrative model, warm handoff kind of thing. But for the time being, we're still just doing traditional therapy. And we've experienced the very things people have been talking about with there being like a bottleneck at times between a patient wanting to be seen or needing an assessment, and it just depends on the availability of the week. Sometimes we can get one seen within a couple of days. Sometimes it's a week or more. I mean, it just depends on what we've got available on the schedule. And that's something we're hoping the integrative model will help us fix.
And Stephen, the way I don't know how big your program is. You said you're not a licensed therapist. What's your training? What's your background?
So I'm a MD MBA, and I'm the unit manager. So
because I think, yeah, I mean, in your organization, do you use people that aren't necessarily licensed therapists, or you're doing the traditional model and so you need licensed people in order to bill?
so far we're doing a straight traditional model, and we need licensed people to bill. This is how we've done so far.
Okay. And one of the organizations I work with are doing the traditional model too. And what they did is they took everybody and everyone gets a half a day block of being there, sitting in the office, in the, doctor's charting office or whatever, and they're doing warm handoffs. And the other 32 hours a week or 36 hours a week, they are in their office doing their thing. And so that's one of the ways that they at least got started. Everyone had a half block. I don't know if you have enough staff to do that.
Yeah, we've got about 4 therapists, but they're all part-time. We're hoping to hire some more staff as we get additional grants and things coming in. But for the time being, we're just not really set up to do that with the staff we've got and the hours they're available to work.
And I would say for those of you, and I think everybody's a community health center, the brief interventions, so the 90832, where you're billing the half-hour session, you get the same amount of money as if you bill a 90834 or a 9083, whatever that is above that. So whether you bill 30 minutes, 40 minutes, 50 minutes, 60 minutes, you get the same rate. So if you're billing 2 90832s in the hour instead of just one 1 hour therapy session, financially, Stephen, it can actually be a model that helps you be able to hire more staff. So there's a financial benefit in a CHC model to using briefer interventions and utilizing your staff's time. And it's also good. I don't know what your no-show rate is, but everyone out there should calculate their no-show rate, because not only do we have waits, then we have no-shows. And so again, we have unutilized time where no money's being made. And I get a chance to take a bio break and go get a cup of coffee. But at the end of the day, that's more people waiting to be seen because I have a no-show. And our population historically no-shows because the social determinants of health will suck up their time long before coming to see you for therapy is somewhere behind getting something to eat, a house over their head, the kids to school, a sick kid to school, and maybe getting gas in the car. They don't have money for put gasoline in the car to come to you. So if you historically have that population, I don't want to call it double booking. I want to call it 2 30-minute sessions in an hour. You make double the money if they show up. And if they don't show up, there's no show. You might can extend that last appointment a little bit more or use that as charting time. So that everyone gets to go home on time at the end of the day. I don't like people having to sit and chart at the end of the day. That makes me sad. I think folks should be able to get home. But thank you, Stephen, for that, and good luck as you move into integration. It's a mindset change for you, for the PCPs, although half the time the PCPs are asking for it. Sometimes they might ask for it before your behavioral health team is ready to go. They just
that's kind of where we are. They want to be able to refer a patient stat. They want everybody right now. And at least currently we're not set up for that. I mean, it's just not even feasible right now. So
and you have to be super careful, Stephen. Sometimes they'll just try to use you as a crisis service. And for those of you that have been in integrated behavioral health for a long time, that is not. That's something you do. It is not all you do. So I've seen sites where that is the only thing that PCPs refer for is a crisis, a PHQ-9 with they answered 1, 2, 3 on question 9. And you really want to be careful about that. What you could do, I have found, is you can go in there, Stephen, and do those warm handoffs, do a brief intervention, and then the patient does not need to be referred to your mental health team, to your therapy team. You gave the patient what they wanted in the minute. Thank you very much. That's all I need. They learned a skill. You gave them you reframed what was going on, and they're good. And it's one less person that gets referred to you and potentially no-shows. That's other beauty of the integrated care. And if you reach the level of a 90832 in that simple warm handoff, if you reach the level of a 90832, you can actually build a warm handoff as long as you have a diagnosis. So there's all kinds of cool things that can happen. So I wish you guys luck. If the PCPs are driving it, just be careful, because you don't want to be the crisis team. You know, stat means, oh, I got something going on in my office, versus, hey, I'd like you to meet this person in my office. They're an expert in the kind of stress that you're having. They're right down the hall. Let me grab them and introduce you. That kind of stuff. That's what you really want. Not that you guys become a crisis team, but mental health in primary care is crisis after crisis after crisis right now. So it is trying to sort through it. I'm glad you're doing it. It's the right thing to do. I know it will take some work, and a lot of these people on this call today have been doing it for a long time. So lean on your colleagues. Thank you, Stephen.
Thank you.
What else? Anybody else? Anything else they want to add? I know a number of you are from Winches. We got the whole Winches team here. We're getting a special Winches consultation, Jessica. Any other questions? I know I'm going to see a couple of you. Amy, you're going, right? You're going Thursday next week? Okay.
Yeah, I'll be there.
Right. We'll see a number of you next week. Anybody else? Any last comments? I'll get 5 minutes of your day back if you guys need it, want it. We don't have to keep going here if folks have said what they want to say. Just want to make sure everyone's had a time to pitch in and ask questions. Okay, looks good.
I think this has been great. Thank you so much, Lori. This has been helpful.
You're welcome, Jessica. Sorry to miss you next week.
Yes. Actually, I will also be at a conference, and you, are we still having this next Wednesday, even though,
Yes. Yeah, I'm not leaving for Raleigh until after this. So we're gonna do measurement informed care next week. You know, is any of this stuff working is the kind of the premise of it. And then after I do this, I will head to Raleigh. And then some of you are going to the EPIC conference in
Okay,
New
I
Orleans.
will.
How exciting.
Yes, yes, and it's a learning forum, so it's more than like hands-on Epic. It's a lot of like we'll be talking about like collaborative care in schools and like
I lost
initiatives
you.
we have going on.
Yeah. Yeah, for I guess some of you that have Epic for your integration, you will be spending some time. Some of you, Jessica, there's folks all over North Carolina going to the Epic conference, and I'm guessing other folks from this call too. So, all right, guys, I'll see you next Wednesday. We will start talking about how do we know if it's working, and we'll go from there.
Okay.
Take care.
you.
Celebrate moms.